And the first principle that I think is really important to think about is the idea of sequencing therapy. And what do we mean by this? Well, if your patient is early in their illness or treatment naive, they've never really been on medication before, they've been on very few medications, you really want to start with antipsychotic monotherapy and to maximize the dose of an individual drug to the point of tolerability versus trying to give someone multiple medications right from the start. Now, if you've done this a couple of times and the patient's had a couple of antipsychotic trials, one thing I think often gets missed is the idea of possibly putting the patient on clozapine. And so we have this tendency to think of clozapine as the absolute last-ditch drug. You fail 3, 4, 5, 6, 7 drugs, fail combinations, then maybe you'll think about clozapine. And yeah, you can put those people on clozapine, and clozapine will often help those people. But really, you want to think about clozapine much earlier than that in treatment. I'm also a huge advocate of using long-acting injectables early in treatment. They're more convenient. In general, patients who are on them actually like being on them. This is different than the popular perception of your patients not liking injections or needles or so forth, that when you actually survey patients that are on long-acting treatments, they really like being on long-acting treatments. The other thing to keep in mind is which medications to start with. So other than clozapine, which is kind of in a category by itself, if you look at the initial response rates to different medications in the antipsychotic class, the response rates, especially early in treatment and for treatment-naive people, they're pretty similar. There's not a huge edge to putting someone on one atypical versus another atypical. And so it's not a bad idea to think about starting with something that has a better tolerability profile. So something that has maybe less weight gain, fewer metabolic effects. That's going to be good for the patient in terms of their long-term medical well-being, and is also going to be good in terms of their adherence, because as we heard, weight gain and other metabolic issues are going to be one of the leading causes for discontinuations. On the other hand, there are going to be some patients who do need those higher metabolic risk drugs. And in particular, one that we work with a lot is olanzapine. And I think any of us that treat patients with schizophrenia are familiar with olanzapine, and we know that there are some patients who appear to respond to olanzapine that perhaps don't respond quite as well to the other medications, with the exception of clozapine, of course, again, in a different category. But we do have many patients that require olanzapine. And so what do you do when you need olanzapine, but you are worried about the risk of significant weight gain because the patient is already a little bit heavier, or they have significant metabolic issues? What can you do? Well, this is one option. This is the olanzapine-samidorphan combination. It's indicated for schizophrenia. And just so you know what this is, samidorphan is a mu-opioid receptor antagonist. Think naltrexone, but much, much, much stronger at that receptor than naltrexone. So an order of magnitude greater activity at the mu-opioid receptor compared to naltrexone. And as it turns out, when you add this to olanzapine, it does appear to reduce weight gain over the 6-month period that it was studied for this drug. And so if you need olanzapine, because that's the thing you respond to, but you're trying to reduce weight gain, this combination might actually be something to look into.